Nasal injury is the most common type of facial trauma. It often occurs as a result of motor vehicle accidents, assaults, falls, sports injuries, and occupational injuries. Most nasal injuries do not require immediate intervention, but trauma that results in a septal hematoma is an exception. This cartoon depicts a cross-section through the cartilaginous portion of the nasal septum. A septal hematoma is blood that collects in the space between the septal cartilage and the overlying perichondrium. This may deprive the septal cartilage of its blood supply from the overlying mucosa, leading to permanent sequelae. Thus, all patients with nasal trauma should be promptly evaluated for septal swelling. If a septal hematoma is present, it should be incised, drained, and packed to prevent recurrence. Prompt treatment of septal hematomas should prevent complications such as ischemia of the septal cartilage leading to permanent necrosis. Such complications can occur rapidly within as few as 3 days and can result in a saddle nose deformity. The saddle nose deformity seen here demonstrates the important tip support provided by the cartilaginous septum. Examination of the nose can be accomplished with either an otoscope or a nasal speculum with a headlight or overhead light source. If you're going to use an otoscope, use an operating head attachment in case incision and drainage are required. We prefer a nasal speculum because it provides much wider exposure. Insert the nasal speculum with the tips positioned superiorly and inferiorly to avoid touching the sensitive nasal septum. With proper exposure, you'll be able to visualize the nasal septum, the inferior turbinate, and a portion of the middle turbinate. Your view of the nasal passage may be partially obstructed by these structures. With minimal obstruction, it is often possible to visualize the nasopharynx. Normal nasal mucosa is pink and healthy appearing, without ulcerations, crusting, or bleeding. Normal anatomy varies widely. Furthermore, there are variations that are not normal, but that are common. These include septal deviations, spurs, and an enlarged aerated middle turbinate. In addition, people may have common pathologic features, such as pale or inflamed mucosa, purulence, nasal polyps, or a septal perforation. Lateral bulging of the septum and fluctuance that persist after nasal administration of a vasoconstrictive agent, such as oxymetazoline, are strongly suggestive of a nasal septal hematoma. An external nasal deformity may not be evident. A septal hematoma is highly likely in patients who have trauma and a sudden onset of nasal blockage that does not resolve with the removal of blood clots and the administration of a vasoconstrictive agent. Gather the following equipment: a local anesthetic, such as 4% lidocaine, mixed in equal parts with a vasoconstrictor, such as 0.05% oxymetazoline, cotton balls shaped into long, thin pledgets and soaked in a topical anesthetic mixture, 1 or 2% lidocaine with epinephrine at a dilution of 1 to 100,000, a 1 cc syringe with a small needle, such as a 25 gauge, to inject the lidocaine, a 5 to 10 cc syringe with an 18 to 20 gauge needle to aspirate the hematoma, a scalpel with a number 15 blade, headlight, bayonet forceps, nasal speculum, suction-tipped catheter, strip gauze or a nasal tampon. Anesthetize the nose with the cotton pledgets soaked in the lidocaine and oxymetazoline mixture. Place the pledgets along the septum in both nasal cavities for maximal coverage of the surface area. Topical anesthesia is usually achieved within 10 minutes, at which time you can remove the pledgets. At this point, the patient will usually tolerate injection of a small amount of lidocaine with epinephrine into the superficial area of the septal epithelium. Note that the mucosa will blanch in response to the epinephrine. Attach the needle to the syringe and use it to aspirate the hematoma cavity. Clotted blood is usually withdrawn easily. If you're concerned about infection, send a specimen for culture and sensitivity testing at this time. Hematomas are also susceptible to secondary infection, usually with Staphylococcus aureus. Community-acquired methicillin-sensitive or methicillin-resistant Staph aureus is usually sensitive to doxycycline or trimethoprim sulfamethoxazole. After aspiration, use the scalpel to cut through the septal epithelium and into the hematoma cavity, making an incision large enough to prevent reaccumulation of the hematoma, about 5 to 10 millimeters. As seen here, the initial incision is not large enough to ensure adequate drainage. Extension of the incision allows insertion of a small suction-tipped catheter to remove clotted blood and examine the septum for necrosis. In this patient, the septum appears healthy. Nasal packing is required to prevent the development of another hematoma or a seroma. The two primary types of nasal packing are with sterile gauze impregnated with petroleum jelly and the nasal tampon. Both procedures will be discussed here. Using a nasal speculum and headlight, employ a bayonet forceps to layer 1/4 inch gauze impregnated with petroleum jelly into each of the nasal cavities. Be sure that you place the free end of the ribbon-like gauze so that it protrudes slightly from the nose, and then loop it backward along the floor of the nose. Loop the gauze from the floor of the nose upward. This ensures an orderly placement for compression. Place the final end of the petroleum-impregnated gauze so that it protrudes from the nares as well. Once you have completed packing the gauze, it will fill the nasal cavity and should prevent the reaccumulation of the hematoma. The use of one uninterrupted strip prevents any packing material from being left in the nasal cavities during removal. Gauze packing is time-consuming to apply and can be unpleasant for the patient because it is uncomfortable and because packing material can adhere to the nasal mucosa, complicating removal. With the nasal tampon, a nasal speculum and forceps are used to insert the tampon along the septum in the same horizontal plane as the earlobe. The nasal tampon is inserted until its end is at the nares. Once the packing material is in place, a syringe with sterile saline solution is used to expand it, so it fills the anterior nasal cavity, providing compression and preventing the formation of another hematoma or a seroma. The nasal tampon requires less time to apply and is less unpleasant for the patient. The packing material is left in place for 3 days. While the packs are in place, the patient should take an antibiotic that will guard against staphylococcal infection. With resolution of the hematoma, the septum will generally heal within 1 week without any evidence of the incision. The mucosa should appear healthy and smooth. Complications can be divided into early and late on the basis of their appearance. The most common early complication is the formation of a seroma, owing to fluid reaccumulation after nasal packing material has been removed. Aspirate the seroma and place new packing material as needed, as in the initial treatment of the hematoma. Hematomas are susceptible to secondary infection, which can usually be prevented by starting the patient on an antibiotic regimen right after the procedure and continuing the treatment while the nasal pack is in place. If an abscess is present, send a specimen for culture to ensure that the antibiotics you have prescribed will provide adequate coverage. Culture-directed therapy will help avert dangerous late sequelae, including intracranial extension of a septal abscess. If the hematoma is not promptly drained, destruction of the septal cartilage can result in the saddle nose deformity seen here. In summary, routine examination of the nasal septum after trauma will allow for early identification and treatment of a nasal septal hematoma. Prompt treatment will help prevent unnecessary complications and can be performed in a wide variety of clinical settings.